It's my privilege today to discuss with you genomic profiling in early stage estrogen receptor positive breast cancers, how this relates to precision medicine. These are my disclosures. The issues I will discuss today relate almost entirely to those that relate to clinically relevant issues. I'll discuss clinical management, but also aspects of research, just a few aspects of research. I'm going to talk about molecular subtyping, the drivers of molecular profiles and how these might differ and impact in premenopausal women. Some recent unpublished data on TP53 mutation, how this might act on prognostic estimations. And lastly, then to discuss estrogen dependence of estrogen receptor low tumors, this cohort of tumors, which has been recently defined by ASCO-CAP recommendations, I should say. I'll also discuss a few things in research, particularly the artifacts to avoid, or some of the artifacts to avoid, and then also key pathways of endocrine resistance. We've also done recent work on key pathways of resistance CDK4/6 inhibition. These will be summarized by Jean Schuster in the Spotlight session on Friday. The genomic profiling of estrogen receptor positive breast cancer, indeed of breast cancer overall, probably relates, goes back to and starts with this really instrumental publication by Peru and his group on molecular portraits of human breast tumor, where we could see that by doing hierarchical clustering of gene expression that was derived from microarray analyses, one could get these groupings of tumors coming together. At that particular stage, they did not, in that first paper, describe the subtypes that we become very used to using, the luminal subtypes of basal-like and estrogen receptor, the ERB2-like subtype. It's in this second paper, first authored by Sori there, that they did this. And in fact, you can see here that the critical aspect was that some of the subtypes, particularly the luminal A subtype, had better outcome than other subtypes. In this first paper here, they also describe luminal B plus C tumors. That is no longer actually used. We just talk about luminal B tumors. In many ways, I think this is I'd say more accurate, but a more, for me, informative way of doing this. This is a less cited paper, but I think this relates particularly to one of the issues I wanted to draw to your attention today. And in this particular paper, the branches in the tree here are only colored if there is clear statistical evidence that these tumors are indeed of a subtype A, subtype B, and the gray lines here indicate tumors with a low correlation. In fact, this relates to nearly 30% of tumor types in this group, with no particular confidence that these relate to a given subtype. More recently, the group here with Matt Ellis, Joel Parker on this first paper have actually reduced the number of genes down to just 50 to describe the subtypes. And I think this is the way that almost everybody thinks about the subtypes being driven now by the so-called PAM50. On the right-hand side here, you can see the estrogen receptor positive patients from this study, and you can see that, as we'd expect, almost all of the estrogen receptor positive group are in fact luminal A and luminal B. You can see how much worse the luminal B outcome is in this study. But how are these subtypes actually derived? They're derived by actually relating the correlation of the 50 genes in our unknown tumor here on the left-hand side to what I think of as archetypal or average gene expression for the luminal B, luminal A, and HER2-enriched basal-like. You can see that in this particular example, this tumor is a much more similar look to the luminal A and will be called luminal A. But this is a continuum, and clearly tumors could be quite like luminal B or luminal A and have to be called one or other. We don't talk about luminal A stroke B tumors. So I want to show you the consequence of this in this small study that we did here. We've taken core cut biopsies at diagnosis and surgery with 2 weeks in between, with no intervening treatment. And we've then placed the core cuts into RNA later to ensure that there's no degradation of the RNA, and then subtype these. In the panel here at the bottom, you can see that in 42 of the cases, we have exactly the same subtype called, most of the tumors being luminal A. But in 14, that's 25% of the 56 patients, the call was discordant. And why was this? On this diagram, we show the correlation with the luminal A subtype here on the top panel here for the concordant tumors and the discordant. These are in order of the degree of correlation. And you can see for the discordant tumors, they are relatively low in expression compared to these up here. And they're in some cases quite like luminal B. And then in the surgical sample over here, you can see that although the luminal B was called, they are quite like luminal A. There is no major distinction between these two subtypes. And then similarly for the group that were called luminal B at the time of diagnosis, those which were concordant, these tumors are similar to luminal B. But when we get down to these which, if you like, switch between the two diagnosis and surgical samples, we have similarity between the luminal A and luminal B subtype. So because of this continuum between luminalness and luminal B-ness, there are some middle tumors, which in cases where you take two biopsies from the same tumor, you'll get a different result. And to some extent, this also relates to the closeness between luminal B tumors and HER2 enriched. I now want to switch to the issues relating to understanding the makeup of the molecular profiles. What are the biological phenotypes which drive the results which we get from these clinically used profiles? So this is, you'll well know, I think, the oncotype genes, the 16 informative genes, if you like, and the 5 reference genes. And most people, and indeed I, used to consider that proliferation was likely to be the main driver of the oncotype genes, oncotype result rather, the recurrence score, because there are 5 genes here, and then also because the coefficient here, 1.04, is the highest of the coefficients. But one thing to note is that if the result of the proliferation group score is less than 6.5, then those tumors get given a result of 6.5, and that has a profound impact. We published just last year the correlation between the proliferation module and for the recurrence score, as you can see here on the left. And this is just an R of 0.36, a very low correlation. When you actually apply this threshold, nearly 80% of the tumors actually now given the same result in the overall algorithm. The driver, the main driver, as you can see here of the recurrence score, is in contrast to what most of us thought, is the estrogen module. As you'd expect, the recurrence score, the correlation rather, is negative here with a correlation coefficient of in fact nearly 0.8. So what about the other commercial tests that we use? This is the risk of recurrence, the Prosigna, the EP, the EndoPredict, and then the breast cancer index here. And this takes the proliferation module from the recurrence score and the estrogen module, and can see that for the ROR, the proliferation module has a very high correlation with the overall ROR score. And the estrogen module doesn't feature at all. For the EP-Clin and the BCI, there is if you like, a rather less relationship, but still strongest relationship with proliferation. The estrogen module does have an impact on the EP-Clin, but very little with the breast cancer index. A fairer actual statistical way of actually considering this and describing this is on the right-hand side. We find that 19% of the information we get from the recurrence score is from proliferation, but actually 60%, 3 times as much from the estrogen module. In contrast, the ROR is driven very strongly by proliferation, actually nothing by estrogen. Then the EP-Clin and the proliferation and the BCI are somewhat in between. So what about estrogen levels in patients? Do these actually relate to the expression of some of the genes that we commonly measure? And how might they affect gene expression in some of these commercial signatures? So many years ago, actually at the San Antonio breast cancer meeting here, Anita Dumbier from our group described that in postmenopausal women, there was a correlation between plasma estradiol levels and the average expression of these 4 estrogen-regulated genes. So we actually asked more recently, given the differences in estrogen levels are quite small between postmenopausal women, was this of relevance, of impact in premenopausal women, clearly where the estrogen levels are much higher? So these are data by Ben Haynes, published several years ago in a cross-sectional study where we had 175 patients in whom the menstrual positioning at the time of diagnosis and the time of biopsy was well known and well described by the group at the European Institute of Oncology. And we found that in this window 1 here, where we have low estrogen, we have lower levels of the estrogen regulated genes compared to window 2, where we have the highest estrogen levels in the menstrual cycle, and then middle levels here, where we have intermediate levels of estrogen in the menstrual cycle. More recently, we've described this in a longitudinal study, and we can see these paired biopsies where a patient moved from window 1 at diagnosis through to window 2 at surgery. And you can see indeed the estrogen regulated genes here do indeed increase, minor decreases then through the time when we get into the luteal phase. And this does appear to have some, but lesser effect on proliferation gene. So how might that impact on the commercial prognostic gene signatures? I showed you that we have estrogen regulated genes actually involved in several of these signatures to a high degree. Well, in fact, we did this study just published very recently, where we have window 1 described in the same fashion as on that last slide, but window 2 is now a composite of the 2 and window 3 that we had in that study, just because of the numbers of samples we have. So we have low estrogen with the absence of progesterone actually compared to high or moderate estrogen in the presence of progesterone. So there's no change overall in these patients. You can see that the actual signatures overall are actually quite stable. But one thing we did observe was if we actually look at samples and differences between the gene expression, when 2 samples are taken in the same window of the menstrual cycle, the variability of the scores is much higher in those where we have a comparison where the window is different. So there does seem to be an impact of these hormonal levels on the outcome of the recurrent score, the ROR and the EP-CLIN, but these are not systematic as far as we can describe, at least using the windows that we've actually applied in this study. So more recently, we've, and this is not published yet, we have a paper in submission, we've actually asked what is the biological responsiveness of this estrogen receptor low category. This has been recently described as like a new category and distinct category by immunohistochemistry in recommendations from the ASCO CAP Guidelines Committee. We've actually asked how does this group respond to estrogen deprivation when assessed by immunohistochemistry, and is there a similar level of relationship if we measure these samples by messenger RNA, given that several of these tests I've already talked about do include estrogen receptor in their signature, and indeed there is interest in whether we could replace immunohistochemistry by messenger RNA analyses. The study samples that we used from these were from the POETIC trial, where many of you will know this trial already. We actually have nearly 4,500 patients who were randomized to receive either an aromatase inhibitor, 2/3 of the patients, or no treatment between the time of diagnosis and the time of surgery. Ki67 was measured at baseline and at surgery and was our biological measure of response in this study. These particular samples are in fact not from the POETIC study, they're from an earlier study, but I'm using them here to illustrate the variability in Ki67 suppression that we see. For the study with estrogen receptor that I'm going to describe here, we've actually divided the patients into 3 groups. The worst 15% of responders, illustrated by this sort of patient here, who does show a minor suppression, but still a very small amount of suppression. Good responders in the green here, then intermediate responders as in the white. In this particular study, we excluded patients that had a baseline of less than 10%, since you can get vagaries of counting of Ki67 in this group, which would give a potentially inaccurate impression of the degree of suppression of Ki67. So we have these 3 groups, and we actually then measured the estrogen receptor by immunohistochemistry in this. Just to describe the layout of this particular slide, the residual Ki67 is shown on the y-axis. So 100% is a patient that showed no suppression of Ki67 between these 2 types. All of the 15% of the poorest responders are shown here, we selected about 30% of each of the other two groups to match up with the numbers in the poor responders. The good responders, you can see here, all have an estrogen receptor level above 10% cell stain. And indeed, most of these have a value above 50%. In contrast, the poor responders have lower Ki67 estrogen receptor levels, or rather, I should say, all of those patients that have low estrogen receptor levels below 1% have either a poor Ki67 response, or in this case, just two intermediate responders. And indeed, there's no distinction between the degree of Ki67 suppression between if you're 1 to 10%, this low group, to the negative group here. So there seems to be very little biological response to the aromatase inhibitor, estrogen deprivation, if you've got this low Ki67 value. Sorry, I should say low estrogen receptor value. And if we then move through to say, well, what's the relationship if we look at the messenger RNA level? Well, you get a better continuum of estrogen receptor levels when you measure by messenger RNA and you do by immunohistochemistry. We seem to have a sort of a compression of this high expression group when we do immunohistochemistry. The units of RNA here are I, as it happens, at the level of 10, we seem to have a cutoff quite similar to that which we have with the immunohistochemistry. And this indeed actually segregates a group of a fairly similar size with low estrogen receptor levels with a poor Ki67 response as we get with the immunohistochemistry. But we would need to somehow standardize this method of messenger RNA analysis and expression to make this useful in with other groups. The other thing I want to just address here is whether mutational analyses can add prognostic information to transcriptional profiles. In a recent study with the group from WashU and Baylor with Matthew Ellis, we've looked at 841 estrogen receptor positive tumors from the TransAttack study and done targeted sequencing of all the exons of 83 genes that are associated with somatic changes, and these are described in the Griffiths paper here. You can see that the most common genes here which are mutated were, as expected, PIK3CA, TP53, MAX3K1. And indeed, when we compared the TransAttack samples of the actual incidence and prevalence of these, the mutations in the TransAttack group with a previously published group on tamoxifen treatment from the same group of collaborators, we can see that the distribution of mutations is very similar between the two groups. So we look to see how the wild type of TP53 mutation status actually impacted on the prognostic relationships when we look at the various different gene profiles. The most impactful change was, in fact, when we look at the prosigna, the ROR here, and you can see that when we group the intermediate and high risk groups together here, as we have, we find a major distinction in outcome with T3P53 mutated tumors actually having a much worse outcome despite having a similar estimate of risk using the prosigna test. Looking at this for the low risk tumors, there were fewer P53 mutations there in terms of actual percentage, and as you'd expect, these actually have a little impact on the overall outcome. One of the things that we've been increasingly aware of are the artifacts that can occur during transcriptional profile. And I want to draw just one of these to your attention because I know it is in one or two of the studies which have recently been published on transcriptional profiling in receptor positive patients. So again, this is taken samples from the POETIC trial. And in this case, we have, again, core cut biopsies taken from patients just from the control group here, or the aromatase inhibitor group, but a subset of patients in whom we have RNA later samples and in whom whole genome expression arrays were conducted. We have 157 patients that were aromatase inhibitor treated compared with 56 untreated. If we look at the number of genes that actually were changed in the treated group, larger numbers with 3,269 genes changed, but there were a group of genes changed in the untreated group, 110 at this low p-value. Now, if we compare these in these two tables, these are the tumors on the left-hand side, the genes rather, ranked in order of their change in the control group, with FOS, RGS1, DUSP here, all changing by 3 logs in the control group. And when we look at the aromatase inhibitor group, we find that these are also the 3 top genes. Down at 4, we do get TFF1 change, which is a very highly estrogen regulated gene, TOPO2 here then, but FOSB, HBB, HBA2, these genes are changed almost exactly the same in the aromatase inhibitor treated group as in the control. So if we plot these out, we're looking at the ratio of the gene expression change in controls along the x-axis, aromatase inhibitor on the y-axis. There is this group of tumors which have the greatest change here, in that are exactly the same in degree of change in both the aromatase inhibitor and control, and in the absence of a no treatment control. I think we will be focusing on these genes for our understanding of what's going on in the tumors. So I'm going to move on just now briefly to looking at some of the key pathways of endocrine resistance that we've looked at in the recent past. We've been doing genomic analyses on samples from the POETIC trial here. You see, again, we've been looking at tumors where we have greater than 10% in the baseline samples to avoid analysis of samples where we have less confidence about the degree of Ki67 change. And we've done a bookend study in which we've compared the 15% porous responders with 50% best responders. We've left out in this study the intermediate responders that we looked at in the estrogen receptor study. So this is the relationship of the Ki67 in those individual patients with the increase in estrogen receptor levels by the messenger RNA levels. And you can see, as you'd expect, this gap here because we've left out the intermediate group. We essentially end up with 3 sorts of tumors. We have the poor responders here with these low estrogen receptor levels. The good responders here, almost all of whom have high estrogen receptor levels. But then we also have this group of poor responders in which the estrogen receptor levels are the same as in the good responders. So we call these poor responders with ESR1 high. And these are the patients' samples which are of greatest interest, since we seem to already have, like here, an explanation of the poor response in the very low estrogen receptor levels we have on that left-hand group. We measured plasma estradiol in these samples just to see whether or not there was a distinction between the level of estradiol in the good responders and poor responders, and indeed there is. In the good responders, those patients tend to have a higher estradiol level in the plasma than the poor responders. And this takes you back, if you like, to one of the earlier pieces I was talking about there. We have this correlation between estradiol levels and expression of some of the estrogen regulated genes. There is no distinction, however, with the poor responders with low ESR1 levels. If you like, these tumors don't actually have the potential to actually relate to or respond to the estradiol levels. So it's no surprise they don't actually differ from the good responders. What about the intrinsic subtypes and their distribution across this? Well, this looks at the, like this panel here is the individual tumors, the subtype in here showing the basal with the red, the pink for the HER2 enriched here. And almost all of these with the low estrogen receptor levels are indeed of that type. If we look at the histogram here, you can see that, say, there's about 70% of the patients with basal, another 25% here with HER2 enriched, and few luminal tumors here. But what I think is of particular interest is that there is a difference between the proportion of luminal A and luminal B in the good responders versus the poor responders with the high estrogen receptor level. Luminal A and luminal B do not seem to differ greatly when we're looking at the change in Ki67 as their response parameter. Most recently, we've done gene set enrichment analysis to try to identify hallmarks of resistance in these tumors. This shows you the data from the lollipop plot here with the significant hallmarks revealed here. Almost all of them are to the right-hand side here, showing that you have greater expression in poor responders versus good responders. And just to emphasize, I'm just looking at the poor responders with the high estrogen receptor levels here. As you'd expect, those tumors with high estrogen response early or high estrogen response late hallmark have a better response, and therefore to the left-hand side here. The large majority of these tumors I've shown in the, these hallmarks are rather, I've shown in the boxed area here, are related to immune signaling. This takes us again back to a much earlier study, which we published, where we're looking at the pre-treatment expression of an inflammatory response metagene and find that that has a correlation with poor Ki67 response. And we confirmed that in a group from Edinburgh, slightly lower R value here, slightly lower P value, but essentially confirming that relationship. So this much larger study in Poetic seems to support that immune signaling is indeed related to poor Ki67 response in estrogen receptor positive tumors. This slide shows the individual genes and their significance, the hallmarks here. And we've ordered these in the highest significance to the left-hand side, moving to the right-hand side. And the immune-related signatures are all in black here. And you can see to the left-hand side of this, we do have some significant issues related to GTM, checkpoint, xenobiotic metabolism, hypoxia, etc. But again, the emphasis is on the immune signatures. We've therefore subjected these to TME deconvolution. And at the present time, there doesn't seem to be any distinct set of immune cells which are actually more or less significated to the poor response than another. This needs a lot more work on it, but I did want to bring this to your attention today, that distinct from our studies in estrogen receptor negative tumors and in relation to cytotoxic chemotherapy response, immune signaling in estrogen receptor positive tumors is related to poorer outcome and poorer response to endocrine treatment rather than better response to treatment. The exact mechanism behind this, we've still got to disentangle, but it's an important part of our current research. So the take-home messages are that estrogen receptor positive breast cancer has wide genomic tumor variability. Intrinsic subtypes defined by the degree of likeness are defined by the degree of likeness to gene expression archetypes, leading to continuous phenotypes. I think we might, also, as well as talking about luminal A tumors and luminal B tumors, we've got this middle group here, which we might think as luminal A stroke B tumors. The oncotype DX is dominated by estrogen signaling and the prosigna by proliferation. The estrogenic environment does affect gene transcription, but it doesn't seem to have much impact on the outcome of these commercial gene signatures and their estimates of risk. There is little biological response amongst these to low tumors. T53 mutation has strong prognostic significance above that in some molecular profiling tests. And multiple pathways of endocrine resistance are present, but with hot immune features being the most significant. There are a very large number of collaborators on these studies. I've listed most of my collaborators here. Those actually are related to the current studies which I've described are highlighted in green. And lastly, these are the funders. I'm very grateful for their support and the support of their donors, and I'm grateful for your attention today.